Assalamu alaikum, starting with the name of Allah, the most beneficent and the most merciful. Let me introduce myself. I am Muhammad Fahad, a student of BS MLT 8th semester from Fahad University of Science and Technology. My registration number is MLT120192075 and my course instructor is Dr. Niaz Muhammad. As you can see on the screen, our today's topic is tuberculosis. Mentioning the outline of the topic, we will discuss the introduction, definition, epidemiology, characteristic of mycobacterium, route of transmission, classification of TB, signs and symptoms, diagnosis, treatment, and summary or recap. Introduction. Tuberculosis is one of the most prevalent infections of human beings and contribute considerably to illness and death around the world. Every year, about 10 million people develop TB and 1.6 million people die. It is spread by inhaling tiny droplets of saliva from the cough or sneezes of an infected person. It is slowly spreading, chronic, granulomatous and bacterial infection characterized by gradual weight loss. Tuberculosis can be defined as it is a potentially fatal contagious disease that can affect almost any part of the body, but is mainly infection of lung. The fatal contagious means it is deadly and can spread from one individual to another. The word tuberculosis is a new Latin word. The tubercle means round nodule or swelling and the osis means the condition. Every year about 10 million people develop TB disease and 1.6 million people die. It is estimated that about 2 billion people worldwide are infected with mycobacterium tuberculosis, often just shortened to be tuberculosis or simply TB. 2 billion is a ton of people. But even though they are infected, that doesn't mean all those people have symptoms. The vast majority, about 90 to 95%, aren't even aware they are infected. And this is because usually the immune system can contain it such that it isn't able to multiply and often remains latent or dormant, as opposed to active, which usually causes symptoms and can be spread to others if the host immune system becomes debilitated at some point down the road, like with AIDS or some other illness. Or as a person grows older, it can be allowed to reactivate or basically wake up and become very serious, especially if it spreads through the body. The incidence of TB worldwide. TB is the 13th leading cause of death and the second leading infectious killer after COVID-19, above HIV and AIDS. In 2021, an estimated 10.6 million people fell ill with tuberculosis worldwide. So the total number of people in the world suffering from tuberculosis is about 1 crore. Asia is more exposed to TB. Including different countries, India has the largest number of tuberculosis patients in the world is about 27%. Total number of people in China suffering from tuberculosis is about 9% of worldwide. The total number of patients in Pakistan is about 6% worldwide. And the other countries like Indonesia, Philippines, Bangladesh, South Africa, these are also included in the Asian. Characteristic of mycobacterium tuberculosis. Mycobacteria are an interesting bunch. They are slender, rod-shaped, and need oxygen to survive. In other words, they are strictly raw. They have got an unusual waxy cell wall, which is mainly a result of the production of mycolic acid. Because of this waxy cell wall, they are acid fast, meaning that it can hold on to a dye in spite of being exposed to alcohol, leaving it bright red color when a Ziehl-Neelsen stain is used. The wall also makes them incredibly hard and allow them to resist weak disinfectant and survive on the dry surface for a month at a time. They have got slow generation time about 15 to 20 minutes. Transmission. Tuberculosis is transmitted through the air, not by surface contact. Transmission occurs when a person inhales droplet nuclei containing mycobacterium tuberculosis and the droplet nuclei transverse the mouth or nasal passages, upper respiratory tract and bronchi to reach the alveoli of the lungs. Now, mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now we breathe in all sorts of viruses and bacteria all the time, but we have got defenses that take care of most of them. For one, air that we breathe in is turbulent. in the upper airways and drive most bacteria against mucus, which is then cleared pretty quickly. Ultimately though, TB can avoid the mucus trap and make its way to deep airways and alveoli, where we have macrophages which eat up foreign cells, digest and destroy them. But in case with TB, they recognize foreign protein on their cell surface and phagocytize them, or essentially package or cover them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with lysosome, which has a hydrolytic enzyme that can pretty much break down any biomolecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits the fusion, which allows the microbacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. TB is classified into pulmonary and extrapulmonary TB. The pulmonary TB is subdivided into primary TB and secondary TB. The extrapulmonary TB occur in kidney, pleural membranes, lumbar vertebra, lymph nodes, brain and meninges, liver and pericardium. The extrapulmonary TB occur when microbacteria gain entry in the circulation and cause disease in different parts of the body. Primary TB, the infection of an individual who has not been previously infected or immunized, is called primary tuberculosis or gone complex or childhood tuberculosis. At this point, somebody has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic or maybe have a mild flu-like illness. Let me explain this text with the diagram present on the next slide. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma. Essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies. As a result, a process referred to as caseous necrosis, which means cheese-like necrosis. Since the dead tissue is soft, white and look a bit like cheese, this area is also known as cone focus. It also gets to highlight lymph nodes, either carried over by immune cells through the lymph or by direct extension of the cone focus infection, and cause caseation there as well. And together this caseating tissue and associated lymph node make up the characteristic gone complex. Gone complex are usually subpleural and occur in the lower lobes of the lungs. This tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on X-ray. This calcified gone focus is called lobe calcification or fibrosis, or a Rinke complex. In some cases, although a scar is left over, the microbacteria is killed off by the immune system, and that's the end of that. In other cases, even though they were walled off, they remain viable and are therefore still alive, but they are just dormant. When a person's immune system becomes compromised, like with AIDS or with aging, the cone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and the TB, being an Arab, prefer areas of greater oxygenation. Since they were previously exposed, the immune system memory T cells quickly release cytokines to try and control the new outbreak, which form more areas of caseous necrosis. This time though, it tends to cavitate, or from cavity, which can allow the bacteria to disseminate or spreads through airways and the lymphatic canals to other parts of the lung, which can cause bronchopneumonia, but it can also spread via the vascular system and infect almost every other tissue in the body, called systemic malaria TB. Secondary TB can be defined as the infection that individual who has been previously infected or sensitized is called secondary or post-primary, or reinfection or chronic tuberculosis. Secondary tuberculosis usually occurs because of reactivation of latent tuberculosis infection. Complication: when TB is spread to other tissue, it causes complications related to the organ affected. Kidney are more commonly affected, resulting in sterile pyuria or high level of white blood cell in the urine. It might also spread to meninges of the brain and cause meningitis. The lumbar vertebra causing port disease, and the adrenal gland causes adenosine disease, and liver causing hepatitis, and the cervical lymph node causing lymphadenitis in the neck and also cause scrofula. The general symptoms of TB disease include feeling of sickness or weakness, weight loss, fever, night sweats, and the symptoms of TB disease of the lungs also include coughing, chest pain, and the coughing up of blood. Symptoms of TB disease in other parts of the body depend on the area affected. Diagnosis or testing for TB often start with a purified protein derivative or PPD intradermal skin test, sometimes known as tuberculin test, Montauk's test, or simply TB test. With this test, tuberculin is injected between layers of the dermis, as you can see here. Tuberculin is a component of bacteria, and if a person has previously been exposed to TB, the immune system reacts to tuberculin and produces a small localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin test simply means the patient has been exposed at some point to TB. It does not differentiate between active and latent disease. As an alternative to tuberculin skin test, there are also interferon gamma release assays or IGRs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you don't need to show up again to have the test read like you do with the PPD. Also, the IGRA is more specific to TB rather than other type of microbacterial infection and is unlikely to be positive as a result. Positive test of having BCG vaccine in the past, a vaccine that protects against TB, and this is a pretty useful feature of IGRAs. Since BCG vaccine is given to many children around the world to prevent disseminated TB after doing a screening test with PPD or IGRA, anyone with a positive result typically gets in. Patient with symptoms like fever, night sweats, weight loss, and coughing up blood or hemoptysis. It is important to collect sample from either the sputum or via a bronchoalveolar lavage, which is where a bronchoscope is inserted through the mouth or nose into the lungs. Fluid is squirted and then the fluid is collected. These samples can get sent to the lab for staining, culture, and PCR to look evidence of Mycobacterium tuberculosis. First line medication and treatment of TB. Treatment of latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically done with different combination of anti-TB antibiotics like isoniazid, rifampin, ethambutol, and pyrazinamide, which result in patient being non-infectious to other usually within a few weeks. Until that point, though, patient can spread TB to other, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms and visitors are asked to wear N95 protective masks that can filter out oil aerosols and for not resistant to oil, but can filter out at least 95% of other aerosol, in this case TB. Even after patients are no longer contagious, they are typically kept on multiple medications for many months to be sure the bacteria are destroyed, usually with direct observed therapy or DOT, where somebody watches and confirms that you are taking the medication. Second line medication like capreomycin, ethiamide, para-aminosalicylate sodium, and cycloserine. Additionally, there is an enormous worry about new drug-resistant strains of TB that are causing infection in various parts of the world. You may hear of MDR TB or multi-drug resistant TB, or even XDR TB, which is extremely drug resistant. And it is incredibly hard to treat because they don't die in the presence of the usual antibiotics. The bottom line is that to get an effective treatment, it is super important to make sure that the drug being used will work against the specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medication are used for the entire course of therapy so that all of the Mycobacterium tuberculosis is killed off. Recently, the US Food and Drug Administration has approved a breakthrough medication for XDR-TB, which is called pretomanate. According to recent studies, a combination of pretomanate, bedaquiline, and linezolid has been effective for almost 90% of XDR-TB cases. As an added bonus, this combination therapy can be taken orally and is also very well tolerated compared with other XDR-TB drugs regimens. Alright, let's have a quick recap. Tuberculosis or TB is an infection caused by Mycobacterium tuberculosis that mainly affect the lungs 3 weeks after the primary infection. The immune system tries to contain the infection by creating a granuloma, and the tissue in the middle undergoes caseous necrosis, resulting in an area called gone focus. TB also extended to nearby hilar lymph nodes, causing caseous necrosis there as well. Gone focus plus the affected lymph node make the characteristic of gone complex. If the immune system becomes compromised, like with AIDS or AIDS, gone focus can be reactivated and the infection may spread to one or both upper lobes of the lungs, where it forms cavities. From cavities, bacteria can disseminate it to other parts of the lungs, causing bronchopneumonia, but it can also spread through the vascular system and infect almost every tissue in the body, which is called systemic miliary TB. Testing for TB. Testing for TB starts with a PPD intradermal skin test or with an IgR blood test, and a chest X-ray can identify signs of active TB disease. In patients with fever, night sweats, weight loss and hemoptysis, a sputum sample can be collected. Culture, stain and PCR can be done to look for Mycobacterium tuberculosis. Treatment of active TB include a combination of antibiotics given for several months, and special regimens are used for MDR or XDR TB. Thank you for listening. If you have any question, you can ask.